All right, let's call the afternoon session to order. Good afternoon, and thank you all for joining us. My name is Mark Tedford. I'm a state representative from Oklahoma, and I'll be moderating this general session. Thank you for joining us for part 2 of our dive into prescription drug affordability boards, or PDABs. Our first session in Charleston focused on education and foundational understanding. Today, we shift our lens toward policy with an emphasis on hearing different perspectives across the spectrum. Our panel today represents a wide range of perspectives in an effort to reflect the diversity of voices in the PDAB conversation. PDABs have garnered a large amount of attention throughout the country the past few years, and as we'll hear today, it has been a bit of a bumpy road. So it's important that we as policymakers understand different perspectives on PDABs and how they have functioned in states that have enacted them. Joining us today to discuss these issues are Brian Reed, Principal of Reed Strategies, Anusha Thodakura, Executive Director of Citizens Action, Illinois, Joel Kurzman, Director of State Government Affairs, National Community Pharmacists Association, Caitlin Lucarello, Deputy Vice President of State Advocacy at Pharma, Sandra Gukian, Vice President of State Pharmacy and Advocacy at the National Association of Chain Drugstores, and finally, Mark Herbacek, Director of Public Policy at AI Arthritis. To learn more about these speakers, you can view their bios in the program and learn also on the app. In terms of format, we'll hold all the questions until all the presenters have finished speaking. First, we'll hear from Brian. So, Brian, you're up. Please go ahead.
Thank you very much, Rep. Tedford. I really appreciate you all having me here. I am also incredibly grateful that you put me first. This gives me an opportunity, I think, hopefully to frame the discussion before we get into the weeds. Because if we know one thing about PDABs, it's very easy to immediately get into the pros and the cons. What data should we be using? What standards should we be using? What costs are real? What savings are real? And I want to start at a slightly higher level and ask the question, what's the purpose of a prescription drug affordability board? What is the problem that we wish to solve with this particular policy solution? Because if you go to your neighborhood barbecue and the topic of PDAB comes up, this is, by the way, a warning not to invite me to your neighborhood barbecue because the topic of PDABs might come up. But if you're explaining this idea to your family, your neighbor, the average American, someone who's not deeply engaged in the system, and you explain kind of the outlines of how it's structured, there are these boards from a state standpoint, and they look at data and they come up with limits for what drug prices can be charged throughout the supply chain. Most people, when you present this idea to them, are going to say, this is a prescription drug affordability board. What we're really talking about here, the problem we're really trying to solve is one of patient affordability. And the good news in the average American's thinking about this is indeed patient affordability is important, and it is a problem. The metric I like to think and talk about, the one that shows up in the academic literature, is we want to minimize the amount of cost-related non-adherence, which is to say people can access the healthcare system, they get a prescription, and then because of cost, they don't pick it up, or they don't take it as prescribed, or they skip doses or cut doses. And this is indeed a problem, depending on how you define cost-related non-adherence. We're talking 10% to 30%. It's going to vary by disease. And I'm going to get to PDABs in a moment, but what we know about cost-related non-adherence is that it is not necessarily related to the cost of the drug itself, the list price or whatnot. It's related to how much patients have to pay out of pocket. So you all are very familiar with this. This comes down to insurance benefit design. What's the copay? What's the coinsurance? A coinsurance at $10 a month has very little cost-related non-adherence. You get over $100 a month, and you get cost-related non-adherence that goes from 30, 40, 50, in some disease states, 70% of people who are getting prescribed a medicine who aren't taking it properly. So the question I really want to ask when it comes to are we solving for patient affordability, is what's going to happen to that out-of-pocket burden. And the good news is the folks at Avalier went and asked 30 payers, insurers, health plans, and said, if you are in an environment with a PDAB, if you are in an environment with a upper payment limit, what's going to happen to that benefit design? And they asked a number of questions, but I think these are the ones that were really interesting to me. So first is, will patients be impacted? Absolutely. Almost every payer said yes. This is not just some structural change to the system that's going to be invisible to patients. Patients are absolutely going to feel the effects here. And you could say, is this a good thing? Is this a bad thing? Well, will premiums increase? Majority of payers said yes. And I want to be clear, 57% said yes. That doesn't mean 43% no. There's a lot of kind of, maybe? So we can almost certainly say that there will be a premium increase. Will cost sharing increase? 50% yes. Again, that doesn't mean 50% no. That's 50% absolutely. We will place more costs on patients. Utilization management. That's formulary games. That's prior authorization. Step therapy. Absolutely. 50% said without hesitation yes. So we know that that other 50% is going to be a combination of maybes and no's. So if we look at the question that we started with, what's the problem we're trying to solve? If we're trying to solve for patient affordability, a PDAB might not be the best way to get there. And there are other state-level solutions. We can talk about passing rebates on to patients. We can talk about modifications to the way copay accumulators are willing to work. There's all sorts of minutia that start getting to this idea of patient affordability without creating an environment that we know is going to lead to patients not taking the medicines that they should have access to. I am not so naive, especially in this room, to think that patient affordability is the only possible reason why people might come to you with the idea of a prescription drug affordability board. What we know is the other problem that we often have to solve is state budgetary concerns. And again, I'm probably the least qualified person to make this statement, but every dollar we spend on healthcare in the state is a dollar we don't have for teachers or cops or roads. So we need to watch those dollars incredibly closely. So the question becomes, is a PDAB a good way of achieving that goal? And the good news is I am going to pass the mic in a moment, and I think the panelists here are probably going to do a pretty good job of outlining that. What I want us to think about is the trade-offs, because if you decide, yes, a PDAB is a good and effective way of addressing state budgetary concerns, you still have to grapple with the fact that there are trade-offs. And I just talked about one of them. When this gets put into place, there's a high probability that patients are going to face higher out-of-pocket costs. So in some ways, you may get savings on the state level, but you're going to do that on the backs of patients. You're almost certainly going to see premiums increased. You are almost certainly going to see cost sharing increase. I am not a state legislature, so I am not going to give you advice on whether or not premiums going up is a good thing politically or economically. But I know you've seen the headlines as we look to 2026 premium increases. In Colorado, the payers have asked for a 28% increase. My guess is that everyone's interest is not doing things that are going to cause premiums to go out of control. So those are the two ideas that, from a framing standpoint, I'm hoping we can pull through. Number one, what is the problem we're trying to solve? And number two, let's have a serious thought about what those trade-offs are, because if there are better ways of squaring the circle, we want to make sure this is the time now, before things are implemented, that we're really having that dialogue.
Thank you, Mr. Reed, for that presentation. Next, we'll hear from Anusha Thodakura, Executive Director of Citizens Action Illinois. You're recognized for 10 minutes.
Thank you so much. My name is Anusha Thodakura, Executive Director of Citizen Action Illinois. We are the state's largest and oldest public interest policy and advocacy coalition. And we support a prescription drug affordability board because we believe that high-quality, affordable health care should be a right guaranteed to all. And we are very far from making that a reality. We support all efforts to increase access to health care, including lowering the cost of prescription drugs through a prescription drug affordability board. Which one is it? Just this one? Okay, so this issue, my slide deck is focused on Illinois, but I promise you that if you swap out the state to whatever your state is, the numbers are going to look very similar. We are here because you're interested in learning about the impact of Prescription Drug Affordability Board because you care about healthcare. In Illinois, this is a poll from 2020. We did another one in 2024 with very similar results about people skipping their medications, rationing them, not filling prescriptions or cutting them in half because of cost alone. People are choosing between affording their rent, their groceries, their heat, or their prescription medication. What we say is that prescription drugs do not work if people cannot afford them. And our goal is to increase that access. And this is the context that we are in right now. Federally, over 17 million Americans are going to be affected by potential cuts to their own health care. In Illinois, this is some of the snapshot of the data about who is going to be impacted by these cuts. So we've been advocating for a Prescription Drug Affordability Board in some way, shape, or form since 2020. And now lack of access to health care is only becoming more and more of a challenge for Illinoisans and Americans as a whole. I'm not going to go into all these slides. These are just some high-level details about a PDAB, but for folks who may be unfamiliar, the PDAB policy that we are at least advocating for in Illinois, it's an independent body. And it reviews affordability challenges and has the ability to set upper payment limits, or UPLs, that affect every single point in the supply chain. I'm going to repeat that. Upper payment limits affect every single point in the supply chain. And that is why we support a PDAB in addition to other efforts like capping copay costs or PBM reform. We just passed significant PBM reform here in Illinois, banning spread pricing and requiring rebate pass-through. But a PDAB, the upper payment limits, affects every single point in the supply chain and can result in savings for Illinoisans. In Illinois, we had two kind of special aspects of our legislation. One is Medicare rate referencing, that as a federal government has negotiations for drug prices through Medicare, that we should simply adopt those prices as the upper payment limits for all consumers, not just those on Medicare. And it also requires a savings pass-through, that any savings to health plans and PBMs will be required to be passed through to patients, but through lower out-of-pocket costs or lower premiums. Medicare rate referencing is a component in the Minnesota legislation, and savings pass-through is a component in a different form in the Colorado legislation. There are two goals to having a Prescription Drug Affordability Board. One is to increase access to medication, to solve the problem that we mentioned, that there's too many people who are going without medication or rationing it due to cost. The other is to create savings, whether it's through lower out-of-pocket costs for patients, lower premium costs for everybody, or saving the state money through savings on state-purchased medications and state employee health plans. I'm not going to go into it, but there's definitions about upper payment limits that we can get into. This is a snapshot of the first 10 drugs that are being negotiated by Medicare. Maybe some of these are familiar to you, but you can see the average spending per beneficiary. This is just through Medicare. And all of these drugs could have an upper payment limit set at exactly the Medicare negotiated rate. And I believe the prices were around 35 to 75% discounted from the average list price for Medicare. So this is another snapshot of, I want you to kind of zoom out and think why we have such unique challenges in our country, why regulation in every other country results in lower costs for consumers, yet we are repeatedly told that those kinds of policies are simply not possible here. For the 10 drugs that Medicare is negotiating, the price in the United States is 3 to 8 times the price in every comparison country. And there's a chart right here with the countries that the Commonwealth Fund looked at. There's a lot of things that can determine affordability. One is how much the patient is paying out of pocket. Another is how much is a health plan spending on the product. Because even if I may not be on a prescription medication, or you may not be on a prescription medication, whoever's paying for our insurance, whether it's a state, whether it's your company, whether it's you as an individual paying that out-of-pocket cost, that is an aspect of affordability as well. And so we in Illinois, the orange box, it highlights that we said research and development costs of the manufacturer and the extent to which those R&D investments have been recouped will be one factor of many factors determining whether or not a drug is affordable and should be considered for an upper payment limit. Again, lots of things that could be considered. Going to keep going. this is getting into the nitty-gritty of how it can be applied. I'll pull these slides back up if it comes to in the discussion. But again, you can see that every single point in the supply chain will ideally be affected by an upper payment limit. In some states, their upper payment limit models haven't been applied to every point in the supply chain. But in Illinois, we think that the upper payment limits need to apply to every single point. It's the maximum that you can reimburse for a drug or bill for a drug. Again, more information. Just going to keep clicking through to a couple slides I have at the end here. Okay. I want to stop here at this slide about R&D investments. So one of the major arguments that we have against any type of regulation, whether it's through a Prescription Drug Affordability Board or some type of federal regulation, which is more than ideal. We should not have to have a patchwork of state-level solutions on prescription drug affordability. But the major argument is that it's going to affect investments in research and development. Well, the blue side of the graph on the left is drug company spending on research, and the right side in orange is drug company spending on advertisement. Only 2 countries in the world allow direct-to-consumer advertising, the United States and New Zealand. So just taking a look, lowering the cost of drugs is not going to affect research and development. Maybe there's some advertising budget that could be dipped into if needed. I think that is the end of my slide deck. Looking forward to answering what questions you may have.
Thank you so much for that presentation. Next, we'll have Caitlin Lucarello, Deputy Vice President of State Advocacy at Pharma, for her presentation.
Thank
Welcome
you
to
very
proceed.
much.
Thank
Thanks,
you.
Representative. I have a couple of slides to help guide my thank you. Well, thanks everyone for having me on 2 panels at NCOIL today. Because you generously gave me the opportunity to go through this. Before lunch, I will skip the slide, but these are the members that we represent in the industry. Anusha went through a little bit of the state landscape, so I'm also just going to do a really light touch on this slide as well. Suffice it to say that right now there are 7 prescription drug affordability boards operating in the state. New Hampshire repealed their prescription drug affordability board this year. I think the important thing here is it really doesn't get into the intricacies of each of these PDABs, as we call them. No 2 are really the same. They're not even always called the same things, but in general, they're tasked with identifying drugs that pose affordability challenges, conducting affordability reviews of those drugs and recommending solutions. And then there's some PDABs with the authority to set upper payment limits and some without. And we'll be focusing quite a bit on those that have the ability to set up upper payment limits in my presentation today. So before I jump into issues with prescription drug affordability boards, I'd just like to say the intent of this legislation is good. Access is extremely important. We talked about that a bit this morning. Affordability is a big part of the access equation. What we disagree on is PDAB's ability to actually impact the affordability part of the equation and worry that instead it will create new challenges with patient access. So there are several structural and operational challenges that limit the ability of PDABs to actually be effective. I'm not going to go through these in order. I'm going to start a little bit with implementation. So these boards are a complex undertaking. Decisions, and I'll say, like, they take a long time. They should take a long time. I'm not encouraging these boards to move faster. I think, agree or disagree with the policy, we all agree that these decisions have long-term implications for access and affordability. So it's important that they're meticulous, it's important that they're thoughtful, it's important that they're methodical. But it takes time to staff the boards, to appoint the boards, to appoint their advisory committee members if they have one, to set up the processes and regulations that are going to govern the board's activities, and then those processes themselves take time, right? Identifying drugs for review, conducting affordability reviews. Now we're in the upper payment limit setting process in Colorado, which I'll get into here in a second. That process is taking quite a bit of time as well. And it's because it is a very data heavy, all of these are very data heavy processes, right? So we run into issues with these boards in gaps in data, in inaccuracies in data, in discrepancies in the data, because of the data heavy nature of their activities. In Oregon, they're in a suspended period on this slide, but they actually resumed affordability reviews yesterday. They had suspended their activities for a year, in part because of the gaps in data that they experienced with respect to certain pricing metrics. And to Brian's point, to re-look at how to define affordability more effectively in their conversations. So Oregon is one of those boards that's been a little bit more reserved about moving forward with an upper payment limit. Colorado and Maryland are moving forward, and Colorado is ahead of Maryland. They have already conducted affordability reviews. They've determined 3 drugs to be unaffordable, and as I mentioned, they're in the process of setting an upper payment limit on the first drug that they found unaffordable. So you might look at this, because I did right away, and I say, like, Caitlin, there's a discrepancy in your data. 2021 to 2025 is not 5 years, it's 4 years. What this is really intended to capture is that at its earliest, Colorado will finalize an upper payment limit, if they do, by February of 2026. And that's a full almost 5 years following bill passage in the state, at a cost of about $3 million spent to that point. Colorado isn't alone in the resources that they are throwing into these prescription drug affordability boards. There's been about $17 million spent across the 8 states, now 7, that have them, and yet none of them have actually delivered on any savings. And I'll actually note, this is from October 2024, so we're in a new fiscal year, so this number is actually very likely a couple to a few million dollars higher, reflect this fiscal year. So we're looking at some supply chain slides today. I think, fortunately, this is a pretty well-educated audience in this area, so I'm not going to belabor the supply chain point. But suffice it to say that the supply chain involves multiple transactions among multiple stakeholders, both inside and outside of the state, and this is replicated over and over with even more actors here. This is a super simple version of a supply chain. An upper payment limit is a cap on, in Colorado, is a cap on purchases and reimbursements for prescription drugs in the state, and I think that is consistent across many PDABs. It's impacting a very specific part of the supply chain. So we hear quite a bit of concern in Colorado from supply chain stakeholders that are very concerned with capping purchases and reimbursements on prescription drugs in the state when their purchasing and reimbursement arrangements take place outside of the state, where an upper payment limit doesn't apply. And they're very concerned that that could have downstream consequences for patient access if you can't get a drug at the upper payment limit in that purchasing arrangement, or be reimbursed enough to cover your acquisition costs. And I'll challenge the assertion of states being able to regulate the whole supply chain. States cannot regulate commerce outside of their state, and impacting commerce outside of their state would run afoul of some constitutional requirements, including the Dormant Commerce Clause. As an industry, we're concerned with an upper payment limit like we're concerned with any other government price cap. Capping prices at an arbitrary point in the process, like the upper payment limit does, creates significant uncertainty from an implementation perspective. It can disincentivize willingness to take risks, and it can disincentivize competition for lower priced generic and biosimilar drugs competing with an upper payment limit drug. There's a lot of criticism that these are veiled threats from the industry, and it's not a threat. You can look at kind of these changes that have happened over time that are great representations of exactly how this works. So in my lifetime, biopharmaceutical research and development in Europe was higher than in the United States. As Europe enacted more and more price controls, as they enacted reference pricing, that research and development investment shifted. It came here. And now research and development investment in the US is 40% higher than it is in European countries. Tying the UPL to the manufacturer or the maximum fair price, the MFP and the IRA, does not fix these concerns. The IRA MFP has not been implemented in states. We already know that companies are predicting significant impacts from the MFP. Nearly 80% of our members surveyed said early stage pipeline projects could be canceled as a result of the IRA MFPs. Plans are reducing and changing formulary coverage, not dissimilar to what you saw in Brian's presentation, where they're saying cost sharing changes may be reflected as a result, premium changes may be reflected as a result. So I would certainly caution using MFP as a metric to get around UPL implementation issues. Not only could an upper payment limit interrupt access from within the supply chain, a positive impact on cost sharing is not guaranteed here. So none of these laws actually ensure a patient benefits from a lower price at the pharmacy counter when they pick up their drugs, or that upper payment limit drugs will be included on formulary or not subject to utilization management restrictions. And in fact, it sounds like we have data to the contrary. And of course, all of those things have implications for a patient's ability to actually access their medicine. I want to say it's not just pharma, not just supply chain that have been raising these concerns. There's been some incredible engagement on this issue by patients. And I think with that, it's time for me to hand over the floor to the rest of the panel who can speak more to this.
Thank you very much for your presentation. Next, we'll hear some comments from Joel Kurzman, Director of State Government Affairs, National Community Pharmacists Association, and also Sandra Gukian, Vice President of State Pharmacy and Advocacy at the National Association of Chain Drugstores. You guys are welcome to proceed.
Yeah, thank you so much. Just by way of introduction, I'm Joel Kurzman. The National Community Pharmacists Association represents the business interests of independent pharmacy owners.
Thanks. I'm Sandra Gukian. I'm Vice President, State Pharmacy and Advocacy with the National Association of Chain Drugstores. We represent chain pharmacy companies, and we define a chain as 4 or more stores under one ownership. So we have regional members that overlap with NCPA, and we also have national chains. And those chains also include traditional drugstores, mass merchants with pharmacies, and grocery stores with pharmacies as well. So as Joel and I proceed, we decided we're going to kind of do a little bit of a tag team here. So we'll be flipping back and forth, and we look forward to your questions at the end of the session. Thank you.
Yeah, thank you. We only have a couple of key messages for you. And the first one is that pharmacies and pharmacists are very much on board with lowering the cost of drugs for patients. Our members work tirelessly to find lower cost options for their patients. This has not always been possible. Please note that it was until 2019 that PBMs could put in their contracts gag clauses which prevented pharmacists from even speaking with their patients about lower cost alternatives, including paying with cash. So with 2019 legislation governing Medicare and Medicare Advantage plans, there are still a lot of opportunities for those gag clauses. And so you will still see in states, efforts to prohibit gag clauses. Even as recently as last year, New York State had to pass a law to enable a pharmacist to be able to talk about lower cost options with their patients. And we see that PBMs are still fighting that effort and not complying. But that's just one example of how our members work with patients. And, as the slide speaks to, it is a key, we're with the patient and feeling very aligned with the patient and very comfortable in conversations like this about how we can lower the cost of drugs for patients.
Thanks, and I would just add that I am a pharmacist. Although I haven't filled a prescription in quite some time, I do remember, and I'll always remember this, there was a gentleman who would come to the pharmacy every week. He had a handful of cash, and that cash needed to be enough for his medication, for his chronic condition, and the food that he was going to have on the table that week. And we worked with his prescriber to find something that he could afford. But I have that image in my mind, and my colleagues who are still practicing unfortunately tell me that all these years later, they still have patients who come every week with that same challenge. So as pharmacists, this is obviously something that really touches my heart. And like Joel said, our members as well as our independent colleagues are working with patients every day to do what we can so that they can receive treatment for their conditions in the way that they can afford. So I think the other comment I just want to make here is just a little bit to tell you about the current environment. Some of you may have heard headline news in your communities about the closure of your local pharmacy. And so we're also very concerned, as we mentioned here, we're putting patients first every day. We're also concerned with these pharmacy closures about the availability of prescription drugs in local communities to patients, as well as the patient's access to pharmacies and pharmacy-delivered services. So what I mean by pharmacist-delivered services, it's not only helping the patient use their medication appropriately so we get the desired outcome and effect, but we also offer prevention and wellness services. We are available if a patient chooses to receive a vaccination. We also can conduct health screenings. We can screen for high blood pressure. We can also screen for diabetes, checking blood glucose levels. So one of the things that we can do as part of our role as healthcare providers is work with the patients who may be in a status of what we call pre-diabetes and helping them to modify perhaps drug therapy, nutrition, and also maybe exercise to try to prevent them from advancing to a diagnosis of diabetes. So we are concerned that some of the actions of PDABs could significantly impact the availability and access to local community pharmacies. So I say this slide's the importance of the right medication. I'd say it's the right medication to the right patient at the right time. So healthcare is patient-centric, and what do I mean by that? What I mean by that is the prescriber making a decision with the patient at the point of care. And then it's also the pharmacist at the point of dispensing. That's also another opportunity for point of care to evaluate, again, do we have the right medication for the patient? So the pharmacy is that sort of last safety net step in the continuum of the supply chain that's already been talked about today. So we have a role to monitor for a patient's allergies, make sure this is not a medication which could cause them to have an allergic reaction. We look at the other drugs that they take. Is there a drug interaction that could cause an adverse event? And also if they're a contraindication, are we aware of another condition that perhaps the prescribing physician wasn't, and we might want to make an intervention on part of the patient. So we do, as was indicated, have concerns about what we call the triad, the prescriber-patient-pharmacist relationship, what impact PDABs could have on that. And then again, pharmacists are just trusted healthcare community providers. I've already talked to you a little bit about our role in the continuum and the types of services that we provide in local communities.
So PDAB legislation, the primary concerns for us is the upper payment limit, in that it doesn't take into account how pharmacies are reimbursed, or is often the case not reimbursed. As you know, NCPA leads the fight against PBMs, and a key message that we convey is just how often our members are reimbursed below cost. And the concern, ensuring a loss. And so one of our concerns when it comes to an upper payment limit is the probability that our members would be reimbursed at a loss. So it challenges the alignment we have with patients when a UPL is not constructed properly to take reimbursement into account. Now, pharmacy reimbursement can be a little bit esoteric, but those of you who have served long enough and have heard from our state association partners, you've probably come to know a little bit about it. But it really is a two-part reimbursement piece. There is the reimbursement for the product, and our members are constantly being reimbursed less than their cost to acquire the product. So that in itself is a challenge. And then there's the costs associated with like having your lights on, paying your employees, being able to provide the clinical services, and that is what comprises a professional dispensing fee. And so anytime you have a reference rate, whether you call it an upper payment limit, whether you call it maximum fair price, if they don't take into account the realities of acquisition of the product and a pharmacist's cost of doing business, then that becomes a challenge.
So one of the things that you are probably starting to hear a lot more about in your state legislatures is what we call a rate floor. And so I think, one of the things that Joel was talking about here is cost-based reimbursement. So I think the largest example of that is Medicaid fee-for-service. In 2016, the Centers for Medicare and Medicaid Services implemented the Covered Outpatients Drugs Rule, which moved to from estimated acquisition cost-based reimbursement to actual acquisition cost-based reimbursement. So CMS contracted with Myers and Stauffer and created a national benchmark called the National Average Drug Acquisition Cost. It's NADAC or NADAC, depending upon where you live. So that is a current one of the newest benchmarks to enter into the healthcare space. And then also CMS requires states to periodically conduct cost of dispensing studies to determine what it is that is an adequate dispense fee to cover all of the things that Joel mentioned and what I mentioned about some of our services like patient counseling, drug utilization review. It includes pharmacy labor costs. It includes rent, insurance, et cetera. So you're hearing a lot more about pharmacists advocating for this cost-based reimbursement. It allows some predictability in reimbursement, which we hope will lead to long-term financial sustainability in the pharmacy business. So we are concerned, again, as we've said, about a disconnect between the UPL price and what the acquisition cost of the drug is for pharmacies.
So this is our last slide. Again, our messages are few. And to reiterate, pharmacies are aligned with patients, seek to be aligned with patients, and would want any sort of legislation around PDABs or UPLs to not break that. And so we value that deeply. So again, the key concern is not the Prescription Drug Affordability Board itself, but the upper payment limit, which can lead to almost probably, if not certainly, under reimbursement. And as you know from our work in the PBM space, we're just not able to concede any more reimbursement losses given the challenges we already face. At least that's how I'd like to summarize it. Sandra, do you have last thoughts on that?
Well, and I know we mentioned the Inflation Reduction Act, and I just wanted to mention, I know that I cover Oregon for NACDS in my role in state government affairs, and they actually are not considering drugs that are being negotiated federally, so they've kind of taken those off of their list. And that's just one example. I just thought I would mention, since we mentioned the IRA, I don't know what the other states are doing. But I think it's important for the PDABs to understand the landscape of pharmacy reimbursement and how that is going to work under the IRA for the pharmacy, which is going to be quite impactful, as pharmacies will be having to float some, maybe up to 30 days, some experts say, the cost of the prescription after it's been dispensed. So that's an interesting model, but again, right now, there's still a lot of questions about how it's going to be implemented, but there are some concerns. And again, we thank you all very much for your time, and we are happy to work with anyone.
May I throw in one last thing, Sandra?
Go for it.
Yeah, so the good news for us is that the fix is pretty easy. When we see legislation that is of concern that does not take into account the two-part reimbursement, it is easy for us to offer language that would set straight. So, for us, it's when we see legislation, it is correctable. It's not as if we have to oppose it without some appropriate attention to the language. So I hope that's helpful from a legislative perspective.
Thank you so much for your comments. And last, we'll have Mark Hobrach, Director of Public Policy at AI Arthritis, for his presentation.
Thank you. I am the Public Policy Director at AI Arthritis, which is short for the International Foundation for Autoimmune and Autoinflammatory Arthritis. However, more importantly, I am a patient. I have ankylosing spondylitis, one of the 22 conditions that AI arthritis represents, and rely on the drugs that would be impacted by upper payment limits set by the PDABs. Now, in my many roles with AI arthritis, I also serve as a legislative lead for the Each Pick Coalition. This is a relatively new coalition, started only about 18 months ago, and it is a national disease agnostic network of about 82 patient organizations and allied groups, as well as probably another 10 to 15 patients and caregivers through what we call the Patient Inclusion Council. They all advocate for drug affordability policies that benefit patients, but it's kind of a unique structure, and I'll get into the next slide why we created this. But it really is intended to operate independently and in conjunction with each other to engage stakeholders as part of the drug affordability process, either at the state level with the PDABs or at the federal level with the Medicare drug price negotiation. Now, the EACH coalition is made up not just of AI arthritis conditions. It is a wide range of conditions that can range from conditions like ours, lupus, rheumatoid arthritis, Crohn's and colitis, to things like epilepsy or multiple sclerosis, bleeding disorders, HIV, etc. We are recognized already as a national leader in terms of educating patients, providers, and policymakers about the costly and ineffective implementation of PDABs and the adverse impact on patients like me from setting upper payment limits for selected drug therapies. Now, the PIC, on the other hand, because it's formed solely of patients and caregivers, really focuses on engaging them to shape healthcare policy through what we call peer-led education, perspective sharing, and activities to ensure that patient-reported needs are incorporated in the drug affordability process. So why did we create this unique setup? And the number one overriding goal is to make sure that the patient voice is being heard in the drug affordability review process at the state and federal level. And that was because early on we recognized that there were some very clear barriers that were preventing meaningful patient engagement at those levels. Initially, the Colorado PDAB and the CMS IRA listening sessions were where we saw this. And I should emphasize there have been some very positive steps that the PDABs have made since this time in terms of trying to increase patient engagement. But it still is very limited in terms of what patient input is received, much less how that patient input is being debated, considered, discussed among the PDABs. We've seen or had situations where patients like myself, because we were affiliated with an advocacy group, we were dismissed out of hand, not allowed to be heard. They told us that they wanted to hear from the 95% of advocates that were not professional advocates. And so our opinions and our input about how upper payment limits would impact us were not considered. We've basically seen through the process that the PDAB officials were understandably more interested in being responsive to the lawmakers, but not so much to the patients themselves. And there were a lot of assumptions early on about how upper payment limits would benefit patients, or assumptions simply that they would without any type of supporting data. Now, I don't want to duplicate a lot of what my esteemed colleagues had already said, so I'm really going to focus on one or two of the main impacts on patients like myself. And the purpose of the PIC and the EACH coalition were really to provide that patient perspective, a disease-agnostic patient perspective, on how out-of-pocket costs are what makes the drugs unaffordable, not the list price, and what types of adverse outcomes can result if they can't get the continuity of care that they need. And a perfect example in my case is the fact that I have several medications, approved alternatives that are out there to treat my condition. Very often the PDABs operate under an assumption that if there are a number of therapeutic alternatives, that setting a cap for one particular drug will not have such harmful consequences to patient because they can choose from other alternatives. But very often for patients like myself with complex conditions, that is not the case. There may be a number of different alternatives, but there is only one that effectively treats our condition, and we have gone through months or years of trial and error to find the medication that works best for us. And if you set a UPL and many of the adverse consequences that have been discussed occur, such as a PBM pulling it off the drug formulary because they can't get the same rebate, or pharmacists not stocking the medication, any of these things could result in me having to start that trial and error all over again, being back at square one and having to take months and years to find another drug therapy that is effective. So this slide is on our website. I mainly put it up here as reference. It talks about a lot of the myths that have associated with UPLs. And probably the ones that I really want to focus on are the fact that there is an assumption that UPLs will cap patient costs. There is no mechanism in most of the states for that to happen. I know when Maryland expanded their UPL authority earlier this year, the Maryland Insurance Commissioner testified about the fact that she had no authority to change an insurer's cost-sharing benefit or cost-sharing design because of a UPL. Her authority rested mostly on modifying or rejecting premium increases, rate hikes. There was very little she could do about the out-of-pocket costs. So simply because a UPL is set on a particular medication does not translate to lower out-of-pocket costs for patients. And that translates to affordability, not what the price of the drug is. We've also seen assumptions. Most recently, there was a PDAB meeting just a couple days ago where PDAB officials were under the impression that setting a UPL would apply to all drugs for all plans in the state. Obviously, that's not the case. There are only certain plans, as I'm sure all of you are well aware, that states can regulate. And it's a very small subset of all the commercial plans that are out there. So there was that myth as well. And just the fact that there is nothing that is being done through the PDABs or setting UPLs that limits the negative impact of PBM practices on patients. And that is really where the most productive reforms would take place. Now, Brian mentioned the Avalier Health Study earlier, so I don't want to repeat that, but I do want to highlight a second study that is also very recent that has shown that under the Medicare maximum fair price that was set through the drug price negotiation, the CMS IRA, out-of-pocket costs have already started to increase substantially by 32%. So insurers, in anticipation of that price going into effect on January 1st, have already started to increase costs on patients because they cannot get the same level of rebate from that drug. And so that is something that we expect we will continue to see as UPLs increase. And just to wrap up, I wanted to highlight this one chart from the Avalier study, which really, I think, drives the point home that of all the health insurance executives that were surveyed, by far, patients were the people that were most adversely impacted by UPLs, that they believed would be most adversely impacted by UPLs. So they were not helping, they were actually hurting the people that PDABs are portrayed as being supposed to help. And that's all I have, unless there's any questions later. Thank you.
Thank you so much for your presentation. I want to commend all of the presenters. This is a big panel, 6-person panel. We got started a little late after lunch, and you all were very efficient with your presentations and presented in time. So I wanted to thank you for that. It's left us a good amount of time for questions. So we'll go into question and answer session. If you have a question, raise your hand, and Jack will get that down. In the meantime, I'll kind of start off with the first question that we had, and that was one thing I didn't pick up out of the presentations is what states currently have upper payment limits in place, if someone can answer that question, and what are maybe a couple big takeaways of what they've learned so far? Caitlin, yes.
I do have a slide on this, but I think I can do it from memory. So it's Colorado, Washington, Oregon, Minnesota, and Maryland that have upper payment limit authority at this time. And just Colorado and Maryland that are working toward actually setting upper payment limits. As I mentioned, Maryland's kind of still in the review process. It'll be a while before they're there, maybe later this year.
Any comments about maybe some of the early experiences they've had in rolling those out?
Yeah, and I should mention, I sit on the Colorado Prescription Drug Affordability Advisory Council, the PDAC, which is the advisory council to the Colorado PDAB, which is why I have so much Colorado PDAB, so many Colorado PDAB facts interwoven there. So the UPL process in Colorado is essentially a three-part rulemaking process right now. As I mentioned, it's extremely data heavy. The statute and regulations outline the particular criteria that the board can review in determining an upper payment limit. And most of the process is reviewing that data, again, very data heavy nature, particular pricing metrics. And then there's also a stakeholder engagement component where they've taken voluntary information from the supply chain. I believe they started their process in May of this year and expect it to take, March of this year, and I would expect it will go through at least August. It looks like there could be a delay. It's not really clear yet. So it's a multi-part, multi-month process to get there.
Thank you for that. Next, we'll turn to Representative Stephen Meskers from Connecticut. You're recognized for your question.
Thank you very much. One, thank you all for the presentation. I think the most insightful point to be made from your presentation is the fact that we've got drug prices that are about 3 or 4 times what the rest of the world is paying in the OECD. And a majority of the expenditures seem to be going out in advertising versus research and development. So the framework for me is a question of why should we should be forcing our states with restricted dollars and our citizens to pay 3 or 4 times what they are in the rest of the world. And the framework, I guess the question of whether I chase a PBM to get a benefit or put up a price cap. The real question is, how do you think I achieve a negotiated agreement, given I don't have a federal leadership on that? And does it make sense for us as states to think about coalition policies where we set up upper limits on payments and enact the legislation once we get 3, 4, or 5 states to agree on policy? Because the idea is that we effectively need to get the prices negotiated at some point in the United States. I don't think we're doing that. And so the first question is there an effective way to negotiate prices? And do you see the idea of leading with 3 or 4 states? We had somebody prior talking about compacts for various parts of insurance. And it seems to me if we led from NCOIL with a compact or structure to allow negotiations or suggested upper limits, would we be violating the Commerce Act? Could we avoid the Commerce Act? So I probably would direct it to the woman in green and the woman next to her who seem to have some issues or thoughts about how we work on that. Of course, it's open to anyone, but I'd love to hear your thoughts on how we could get to a better place, because we're not getting there so far as I can see.
I can go first. Thank you so much for the thoughtful question. two parts. One is, why do it's not just that we have to pick it up in our budgets, we are effectively subsidizing the cost of health care and the cost of prescription drugs for every other country in the world that has a sense to regulate the healthcare industry in the ways that they do. And effectively, that puts the cost on your own constituents in your own communities that are struggling to pay the cost of these medications. And to your second part about, what could this kind of look like to put multiple states together, it takes me to another point that one of the reasons why implementation has been slower than ideal is because in every single one of the states where you do surmount the opposition and you do get a prescription drug affordability passed, the next thing that happens is lawsuits. And the lawsuits slow down the implementation. One of the aspects of the lawsuits is questioning the Dormant Commerce Clause and the potential impact that a PDAB can have on economic activity across state lines. I know there are drug purchasing pools that many states do participate in, but I don't think it's been discussed to do like a PDAB at a multi-state level. Ideally, we do this federally. Ideally, we stick with the Medicare negotiations that have been happening and expand those and build upon those and do more work at the federal level, because it is logistically complicated with implementation for pharmacists, for distributors, to do it state by state. But just because something isn't easy doesn't mean that we shouldn't push for it, which is our perspective as advocates.
Yeah, thank you. Thank you for your question. First of all, I think one place where we all agree is the United States is subsidizing the lower prices of other countries. And it's one of the reasons why we need to look here at addressing the cost drivers that are particular to the U.S., while also putting pressure on other countries that benefit from the innovation that's taking place here in the United States. When we focus on kind of the dynamics between prices in this country and other countries, we're often comparing list prices in our country to government negotiated rates in another country. The reality is we don't have the same system, right? Often there aren't these price caps that are government negotiated rates. But we do have negotiations taking place in our system between plans and PBMs and manufacturers that are typically bringing the list price of a drug down about 50%. However, it's not making its way to the patient, right, at the end of the day. Those rebates are being retained. They're being spread across all enrollees in the plan to slightly lower the cost of premiums, and the patients actually taking those rebated medicines aren't benefiting. So rather than looking at how do we take this flawed policy and make it bigger, I would encourage looking at some solutions that address those key cost drivers in our system, including addressing the broken rebate system, including making sure that patients benefit from rebates at the point of sale, looking at delinking PBM compensation from list prices of medicines to help disincentivize higher list prices and favoring higher list price drugs on formulary over lower list price drugs being available to patients. And then just ensuring that patients have some of the benefit designs that truly lower those out-of-pocket costs. Colorado may not have had a good idea with the PDAB, but they have a standardized plan where they have limited the out-of-pocket costs for patients to 1/12 of their maximum out-of-pocket. And the limits are also capped, and they're pre-deductible limits. And when that happens, you get a patient that can budget their drug costs over the month because they know what they are going to be when they walk into the pharmacy. So I'm happy to talk more solutions, but I would look there.
Yeah, just as a follow-through, look, Europe is at we are 3 or 4 times the price of Europe. 50% is not a solution. The problem I have as a legislator is we're compounding healthcare costs somewhere between 7 and 12% a year overall. At 7 to 12% a year in compounding, we're doubling our healthcare costs in the next 5 years, which means a family policy of $26,000 is going to be a family policy at $52,000. The private sector is going to abandon the insurance market, and they're going to ask for a public solution. I worked in banking. I'm not an advocate for the public solution. It's a cost-driven exercise that if we don't address the costs, someone's going to ask for a public solution, and we're going to be left with a public policy on health care, insurance, pharmacies, et cetera. I'm not sure I'm anywhere near talking of advocacy for that. What I'm asking for is structural changes to get the competitive juices flowing so we can achieve those competitive gains here and not have the rest of the world competing and organizing on price structure, and we're just the taker of prices. I think it's a problem that we all see as legislators. So I don't disagree to have an argument on PBMs, but I think it's kind of a distraction. It's kind of, I'm throwing the ball and getting the retriever to chase the ball and not addressing the real problem, which is we're not in a competitive environment and we're getting outpaced by the rest of the world on health care. Thank you.
Let's move on to the next question. That's Representative Rita Mayfield from Illinois.
Thank you so much. I've actually attempted to pass legislation to address part of this problem. And what that would have done, and let me preface this, I have 5 pharmaceutical manufacturers in my district here in Illinois, and I'm very happy to have them. And what it is the price is not that high. It is not the manufacturing cost. It is what happens when it goes from that manufacturer to the patient. All of those extra costs that are added in the middle, that is where we are having the problem. You know, the elephant in the room are the PBMs. We cannot get away from having that discussion. What the PDAB boards are trying to do is what the PBMs were initially set to do, which was to reduce the cost of medication. However, they figured out in the middle, hey, we're not going to pass these cost savings on to the patients. We're going to keep them. And we know that these PBMs are billion-dollar industries. Why do they need billions and billions of dollars? Those dollars are supposed to be passed down to the patients. They're not passing the rebates down. They're not passing the coupons down. None of the cost savings that are coming from the manufacturer are actually hitting the patients. And as we have these pharmacies, that community-based pharmacies that would love to lower the cost of medication because they have that person in front of them, but yet the PBM is saying, no, you cannot give that to them because we're going to suck this cost up. So we really have to address the issue at hand, the elephant in the room, which is the PBMs. Otherwise, we're going to continue to have individuals who are asking, can we purchase our medications from Canada because we can't seem to get our act together here in Illinois. Not just Illinois, but in the United States. That is a big issue, and that is a piece of legislation that continues to be lobbied about within our Prescription Drug Affordability Committee in the House. We want to lower the cost. So how can we do this? Because every time we introduce a piece of legislation that would actually lower the cost of medication, we have the PBMs will surge upon us with 50 hired contract lobbyists to defeat pretty much any bill that will reduce their billion-dollar profit margin. We are not passing the cost savings on. So I love what you guys are saying. I appreciate you being here, but I do believe that we have to have a different conversation. You have to address the PBM issue before we can look at putting limits on manufacturers. We actually have to figure out how can we remove some of that profit margin and actually push those costs down to the patient, which is where they were initially supposed to be. If we're going to do this PDAB model, then you have to remove the PBMs. Maybe that's the piece of legislation that we look at that says that in the states that have these boards, you cannot have a PBM. They will actually take over the role of PBMs. I actually like that idea. I would be happy to run that legislation for you. But again, just thank you for that, and just know that the manufacturer is not the culprit here. They are not the bad guy. Thank you.
More of a statement, not a question. You maybe don't need a response to that. I'm going to go to Chairman Forrest Bennett for a question.
Thank you, Mr. Representative. He's from my home state, and this is the only place he's allowed to call me chairman. I appreciate that. I am one legislator who is open to a public option in part because of the soaring costs here. One thing that I heard from you, and I apologize that I came in a little bit late and missed a couple of the presentations, maybe this was covered more detailed, but either Joel or Sam said something about most states do not have the ability to control the cost specifically for the end user, the patient. That suggests to me that there are some states that have that power, and I'm curious which states do and what we can do in the states, I'm from Oklahoma, that don't have that. And I fully recognize we are, as the legislator from Illinois mentioned, talking about, you know, policy changes that can affect a third of the people in this room that represent various parts of this industry. But the reality is, as lawmakers, that's what we need to do without consideration necessarily for, with all due respect, the comfortability of the industry. It needs to be about the ability for the patient to afford things, and it seems that we've gone as far away from consumer friendly as we can and all the way to what the market can bear and even beyond that. So I can appreciate that we don't want to fully blame the manufacturers, though I do have questions about their marketing budgets and all of that. But what can we do without major shifts in the way that the industry works to empower legislatures to protect the patient?
So not all states with the Prescription Drug Affordability Board have the upper payment limit authority. You will find that many in their initial drafts of legislation may have had some type of UPL authority, that throughout the legislative process, as there were lobbyists hired to fight against the bill and weaken it, there were UPLs taken out in some states in the final form of the legislation. And the reverse has happened as well. In Maryland, they passed an initial board without full UPL authority. It only applied to state and local governments. And now this past session, they passed a full UPL authority for the board to start next year. So that's kind of why some have UPLs and why some don't. And like I mentioned, there's barriers in implementation. Just because you get a Prescription Drug Affordability Board with UPL authority doesn't mean that within 6 months you're going to see a UPL in place. There is litigation that is kind of inevitable because of attempts to delay the impact of a Prescription Drug Affordability Board. Same kind of litigation that happens against the Inflation Reduction Act and the Medicare price negotiation at the federal level. That people that stand and entities that stand to lose profit due to regulation will spend far more money in lobbying efforts than they will to, you know, improve patient care or instead of reducing their advertising budgets. And so a couple of other things that I wanted to talk about is that the form of the PDAB in each of these states looks very different, and many of the challenges that have been discussed here, whether it's about under-reimbursement for pharmacists or about the impact on patients and access concerns, those are things that can be addressed in the legislation. One of the concerns that was repeatedly brought up was that there is no requirement for a reduction in out-of-pocket costs. Well, then put that in your legislation. That's what they did in Colorado. That's what we did in Illinois. But then, again, making that change doesn't make folks that keep saying, oh, there's no requirement of reducing out-of-pocket costs, then they'll find something else to talk about that's wrong in their view about the bill. And so take the legitimate concerns that you are hearing from pharmacists, from patients, and address that in your legislation. We also have a requirement that the upper payment limit is not inclusive of a pharmacy dispensing fee or of a provider administration fee, so that if you have Medicare Part B infused drugs, that there can be separate administration fees outside of a UPL. And it also requires that independent pharmacies that are state licensed cannot be reimbursed less than a UPL. So there are fixes that you can make to your legislation to address many of the concerns that you may hear from your constituents or other entities. And in Illinois, there are about $1.5 million spent just on lobbyists from pharma. And this legislation, it doesn't just affect manufacturers, it also affects PBMs. PBMs can't charge more than the UPL. That's a function of a UPL. It's a beauty of it that it affects every point in the supply chain. But that $1.5 million is just a small subset of total funding to try and stop this legislation. You know, if a patient group that you've never heard of reaches out to you with concerns, you know, do your research to see where their funding may come from and what outside interests they may have in their motivations to reaching out to you about legislation.
Can I jump in?
Yes, sure.
Is this on? Okay. I wanted to make one point. We have seen a trend over the last year away from PDAB legislation. There were several states where we expected to have legislation to create PDABs, and we didn't. And the reason was very simple. We have seen in the states that have gone that route that they have spent millions of dollars. Maryland spends over $1 million a year on theirs. Michigan projected that if they passed a bill, it would cost $4 to $5 million without any savings. So the reason that New Hampshire repealed their PDAB this year wasn't because of litigation. It was because they had been around 5 years, been in existence 5 years, not shown any savings, and were spending a significant amount of money. And so there's been a recognition over the past year that this may not be the way to go. The PDABs aren't as they seemed, aren't the way they were presented, and they were actually costing the state money and they weren't saving any money.
And I'm happy to talk about the ways that payers may be able to get around this idea that, yes, you have to pass savings on this drug off to patients, but that doesn't mean you're going to raise prices on another drug again. And as Mark pointed out, you may not have the option if you're a patient to get to be that picky. So when it comes to policies, because I think you're really interested in policy solutions that are going to help patients most immediately, and I think anything that hits benefit design, states that have banned spread pricing have seen instant benefit that hasn't hit patients at all, because that's truly fat in the system. Anything that hits benefit design, so copay accumulators, that accrues directly to harm patients. And so if we can start thinking about these sorts of regulations as opposed to playing whack-a-mole with a system that we're 6 years in and no one's quite sure how to plug those holes, may get you to goal a little bit faster.
Okay, next we'll have Senator Arthur Ellis from Maryland.
Yeah, thank you, Mr. Chairman. Gentleman at the end, what's your name and what organization you're with?
Mark Hobroch, AI Arthritis.
Mark?
Hobroch.
Hobroch. Yeah, so listen to you speak. You talk about Maryland a lot and the prescription drug board, and you're kind of negative about it. So I'm texting as you speak back and forth to the lead advocate for these boards back in Maryland. And I won't tell you the colorful language they're using to say their opinion of what you're saying, but out of respect for you, I'll clean it up a bit. But they're saying that, especially with that chart you put up there, talk about the myths and the facts, that you're all wrong. And with the changes we put in this year, they haven't been implemented yet, so you're quoting people who haven't made a decision based on the legislation we've passed. So how would you answer that?
I think, as I showed earlier, the fact that the data that we have seen has shown that costs are increasing for patients as a result of this. Under the Medicare drug price negotiation, for example, the out-of-pocket costs have already gone up before those prices went into effect. And so, I don't mean to be negative about everything with Maryland. They have done some very positive steps in terms of patient engagement with the Maryland PDAB.
Well, thank you for that.
I'm sorry?
Thank you for that.
Sure. And they have added patient representation as part of that bill this year to the Stakeholder Council. Those are very positive changes that we like to see. We wanted an orphan drug exemption as part of that bill, as you know. That's another thing that we think is very important. The first PDAB in Colorado actually applied a UPL to an orphan drug for cystic fibrosis. I think there's a recognition among all the PDABs that that was probably the wrong approach. And so, that's something we certainly want to see among other PDABs, is to have orphan drugs exempted. But, as I said before, I think what we have seen is that initially, the data that we have seen, PDABs are increasing costs for patients. They're not showing any savings to the state. And there is, in the case of Maryland, an ongoing expense. I think it's $1.2 million a year to operate the PDAB. So there's a lot of administration that goes into it.
Yeah, thanks for that. And so the final text is the gentleman said he wants to debate you in Maryland. So reach out to me, will you? I'll connect y'all. Thank you.
Could I ask a question? I'm on the panel here.
Sure, yes.
Would you be able to share if your organization receives any funding from pharmaceutical companies?
We do, and that's the standard. I understand that attack, because that's the standard. We would be happy to accept funding from anybody. We do everything we can to ensure that we are speaking in the patient voice. All of the people that are in our public-facing positions at AI Arthritis have conditions that we represent, including myself. So we are people that are speaking as a patient about how it would impact us as a patient.
I think that that is totally appropriate, but there is some element of fear that the companies put to patients, say your medication is going to be at risk if this policy is implemented. And that kind of, the stoking of fear in patients is being misconstrued as organizing of patients from real concerns. Like you said, this policy hasn't yet been enacted, yet there are patients worried about their access due to concerns being planted by pharmaceutical companies.
To be clear, the data Mark showed and the data I showed didn't come from pharmaceutical companies. That came from health insurers and payers. They're not out there fear-mongering. They're just saying, here's how the economics work for us. We can make this drug available at a lower cost, and we're going to push people to that. And how do we push people to that? We're going to create all kinds of hurdles, be they financial, be they technical, logistical, prior auths. That's how we're going to do it. And if we'd rather have the rebates, then we're going to put hurdles in front of your UPL drugs, even if we're supposed to pass those savings on. So again, that's not necessarily the industry's argument. That's what payers are saying. You are setting up a rational set of arguments, and here's how we're going to respond to them. They're probably to be commended for their honesty, but those are not people in the pockets of the manufacturers.
In Illinois, our insurance industry is not opposed to this legislation, and your potential as legislators is to regulate those potential effects. In Illinois, we have insurance rate review, as 34 other states do, that allow for you to reject or modify premium increases after a review of rate increase proposals. And part of that is, if you had a reduction in how much you paid out for prescription drug spending due to the upper payment limits, then your premium should be decreasing or at least staying the same. And as legislators, you are empowered with the authority to give your state agencies that power to oversee and to regulate insurance companies the same way that we are proposing you do with drug companies and PDABs, any action that you can do to make healthcare more affordable.
All right, so it's just about 4 o'clock. I've got a number of people that have asked questions. I'm going to give one more question, and maybe we can get a quick reply. And then for the people that didn't have their questions answered, I'm sure the presenters might stick through the break and be able to answer them then. So let's go to Senator Mark Huizinga of Michigan for the last question.
Thank you, Rep, and thank you, panel, for your discussion today. I think it's fair to say that all of us want to see lower costs for our residents. And I saw a presentation on PDAB in our committee several months ago. And one of the concerns there was that it really only encompassed a small handful of drugs. The full disclosure, before in the legislature, I worked as a healthcare consultant with hospitals and physician groups and things like that. But one of the things that I noted in the presentation that they provided to us was a couple of particular products that were only provided in a different place of service, not the retail pharmacy, which most people think of as pharmacy. And that would be drugs that are going to be infused in places like physician's office and hospital outpatient departments. My comment is that those products are, especially with those that are reimbursed by Medicare, I think the unintended consequence there is resulting in the fact that it will drive massive windfalls to both hospitals and to physician practices, because when you set an upper payment limit, when it's a Medicare reimbursement, you're not going to change CMS's policy. So I'm deeply concerned about that. And I'm also concerned about the fact that we see a state-by-state policy for these kind of things, and that when we pick small numbers of drugs, that the concern is that our constituents will look at this and say, wait a minute, I thought you passed some policy to reduce the cost of drugs, and if we're picking 8 drugs out of the thousands, what's the outcome going to be? It's going to be negligible, and I think there are unintended consequences for all of us there.
To address the second part first, ideally we have more action at the federal level. That is for sure ideal. We can do things like attach our state UPLs to Medicare rate reference pricing, so that as the federal government is negotiating 10, 15 drugs a year, we have automatic upper payment limits that don't need to go through a months-long review process for each of those individual drugs. And in terms of, there was one other aspect you had in your second question.
Well, I was just saying, though, that Medicare reimburses average sale price of those products plus 6% across the country, so we can't tell Medicare what to do at a state level.
For our UPL legislation, for PDAB in Illinois, we had a 106% reimbursement rate, and what we actually decided to do is take out the physician-administered dispensing cost. so that that can be whatever fee that is set aside from the UPL for Medicare Part B drugs. So that is an option. You could also do 106% reimbursement above the UPL. So for your state, you can decide what you do. Oh, and then the other piece about if your drug is not on the list and it's just a few drugs, well, some of these medications have hundreds of thousands of dollars in their price tags for the blood cancer medications, rheumatoid arthritis medications. And if you look at the per person spending, the out-of-pocket costs may be low. But that is because the insurance industry and the state is subsidizing, the cost of the out-of-pocket costs for a patient. So you are saving your taxpayers money, and you are saving your constituents money through lower health care premiums.
I'd encourage you to ask the providers, the community oncologists in your state, how they feel about UPL plus 6%.
Yeah, I'll just add, we have heard from rheumatology providers, oncology providers that are particularly concerned about this. We heard from one oncologist in New Mexico that was really concerned because complexity and markups are baked into the supply chain, right? And it has a potential impact on solvency. What that impact is really unclear at this point. And some of these PDABs, as mentioned, are multiple years down the road. It's no clearer today than it was when this legislation was moving through. Even carving out physician-administered drugs from some of these bills, I think, is an admission that we're not sure how it works, and it may not work the way that we want it to. So thank you.
Very well. Thank everyone for participating today. We really appreciate it. Next, we'll have a